I'm not representing UNICEF because we are going to have the UNICEF representative in the second panel, but I'm the coordinator of the UNFPA UNICEF joint program on female genital mutilation cutting. This is a program that has started in 2008 following the interagency statement signed by 10 UN agencies. And this interagency statement was very, very crucial in the work that we are currently implementing because basically it has built on evidence-based information, evidence-based research conducted during the past 10 years in a lot of countries in Africa, trying really to look at what's works and what doesn't work and how we can improve what we are doing, because there is always room for improvement. And this program particularly is a holistic program, so we are addressing different issues, including the legislation, including the engagement of the media, engagement of religious leaders, and of course the most important, which is engagement of the community. And for the engagement of the community, we also understood that given that it's a social norm, it has been said by different panelists and by Sister Farr, that this is something that is deeply rooted, but also it's a norm. And when you don't conform to a norm, of course you are facing some risk of being marginalized. And what is the most difficult for a family is probably to see her daughter or his daughter to be marginalized in that community where they are coming from. And so it's like a balance between, yes, because even today, a lot of people know what are the risks and and this is maybe harmful for my daughter, and this is why they are even turning to health providers and they're going to health facilities to have the practice done because they want to reduce this risk, and they know that there is a risk today because of our intervention. But at the same time, of course, you have the other elements which is there, which is that norm, that social norm that they need somewhere to conform with. So the way for us to address that is really to look at some culturally sensitive approach and see how to develop that ownership from the community, including owning the legislation aspects in order to really put a hand to this practice. But the movement needs to start from the communities themselves. And the good news is that we were able to really develop that movement. The movement has started, of course, in a country like Senegal, where a very, very traditional religious leader finally, after the implementation of the program by an NGO named Tostan that everybody knows, came and said, we know that this is harmful. Myself, in my family, I face this issue with, some difficulty for the girls, for some of our daughters, but we cannot do it alone. We need to reach the other. Because for us to abandon this practice, we need to have everybody together abandon it at the same time. So this is what we are trying really to encourage with all those public declarations that you're hearing, but behind the public declaration, there is a lot of education in human rights and in health. I will just come now and conclude regarding our theme of today. Our theme of today is bridging, of course, Europe and Africa in this movement. And I think that there is one element that is very important, Mrs. Chair, which is the movement of abandonment that is taking place in a lot of communities in Africa, following the social norm approach, needs to be widely, and need to reach also European countries. And to do that, we need the support of the media. We need also to use different channels. We mentioned social media, but we mentioned also, we have movies also. That when a community is abandoning the practice in Africa, we need to have a movie on that and show it to the communities here in Europe. So this is one way of doing it. The second way, which is very important, where we need to bridge the two continents, is in terms of data, in terms of producing more evidence, in terms of having, because what is happening today is that, of course, we have some difficulty in showing the progress that have been made. It's like we are not progressing at all when you look at the prevalence rate, for example. And there is a need really to encourage institutions from European countries to really link with institutions in Africa in order to generate more data, more evidence based of what is working, but also to, of course, explore more how we can accelerate this movement of abandonment of female genital mutilation cutting. And then the last thing is the media itself, themselves. I think that they are partner. They are a very good partner in a lot of countries where basically we're working. We're working now in 12 countries, moving to 15 countries this year. But what is happening is that, unfortunately, sometimes just one article from media can really ruin what we are doing. And unfortunately, the media sometimes, like, big, sensationalized social events or announcements. And this is sometimes really working against us. So we need to continue finding ways to bring them more in what we are doing. Of course, they have to denounce what is happening sometimes, like the 200 girls in Uganda that were waiting to be cut last December. But at the same time, we need to find a way to have some quick response to some of this article in the media. And this year, for example, we are developing a toolkit, a rapid response toolkit for the government and civil society to be able to react very quickly to some of these media announcements that are not, and that are somewhere not really showing the progress that is being done at country level. Thank you.
Thank you very much, Nafisa. And on this side of the panel, I would like to lastly call on Mrs. Noor from the Thank you.
I'm representing the European Network. I'm originally from Somalia, but I live in Denmark. And I'm very appreciated and get this opportunity to get this opportunity to join you here. To get this opportunity and join you here. And I would like to start this International Day on Zero Tolerance. It is not started yesterday, it started long time. It is 2003 in Addis Ababa. They created this project and it was so nice. And it gave us a very good step. And this second step is going to be more good. In order to prevent FGM, we have to focus on the building the bridge between Europe and Africa, as it is important to involve society from both continents in the fight against the FGM and these harmful traditional practices. We in Europe, we have to work together with the women and the girls in Africa. This is the best thing we have to do it also. And this is also, as far as this already undergone in the circumcision, They are, I can say and confirm it, they consider as they are the professionals. Because the person who is already touched with the veil is the professional. She is the one who is the professional, and then we have to consider that. We also need to involve men, more activities, especially young men, as they are the future husbands and the father also. We establish a unit across the continents and across the gender together, and we can save the women and the girls who are dangerous. Circumcision and active in the tolerance towards the FGM. The problem, the FGM is carried out more than 4,000 years before, and a part of the other countries, a lot of countries, especially we have got 53 African countries practicing this FGM. 3 of the 10 largest citizen groups applying for this asylum in EU today came from African countries where FGM is practiced. FGM is related with the same families in immigrant communities from Africa as in the parts of the Middle East and Asia. There are also the reports that the procedures in that constitute FGM in the name, but in the name of carried out, and the customary surgery operation in January 2004. There was an outcry when the health authorities Florena accepted the proposal from the Italy Geneva who wishes to perform and a light version of FGM to satisfy the traditional demands from African mothers. The doctors agreed that the medical surveillance, that the traditional methods and being taken overseas for the procedure. The medical FGM, however, was widely condemned, although many may reduce some of the risks during the procedure itself.
That we, as well as I think most of the people and agencies represented in this room, have been working on for quite a while. I realize that we have short intervention times. I'm watching the chair. I've prepared a very short PowerPoint going through very quickly the history or evolution of UNHCR's involvement in this issue. And then I'll make a few points related to the theme today. I do have to say, as many other panelists have already mentioned, that many of the points I want to make, I'm happy to see have been touched on by other panelists as well. So if we could dim the lights and have the PowerPoint, I'll go through that just briefly.
Sorry, the computer is just blocked. We need a second to upload the PowerPoint. Sorry.
Well, okay, then I guess I'm just going to have to talk. Let me say what I wanted to show and what I will show, I hope, in terms of the history and evolution of UNHCR's involvement in this issue, is that it's something we've been doing for a long time. Basically, about 20 years or so, we've been, probably more than that, we've been actively involved in it. And there's a whole series of projects, of policy documents, of statements that show the evolution of this issue into our work and practice. That very fact that we've been working on it so long, and it's been something that has been an issue for us, is actually one of the key challenges, I think, that we face right now. I'm not sure if you could call it compassion fatigue or what you would call it, but it's hard for us to get, as I say, I'm working right now within our own organization to re-energize the various projects and come up with new approaches, come up with ways of developing synergies within our own operations to keep working on this issue. And of course, what other colleagues will say is, but haven't we done this already? Haven't we tried this? Haven't we had this and that program after another? And there's clearly no simple answer to it. I think obviously there has been progress, and I can see that even when I go through the policy documents and sort of how the specificity that we come to now and a much better understanding of this as an integral part of sexual and gender-based violence, also much more sophistication on the issues concerning medicalization of FGM. So there's been quite a bit of movement, but it is getting hard to keep people going. I guess one of the things we face is that certainly in the large refugee operations in Africa that we're involved in, for example, Somalis, that's the third largest refugee caseload that we deal with worldwide. And it's the camps in Dadaab. Well, we're just about to get the PowerPoint. The camps in Dadaab, Kenya, which are primarily, or overwhelmingly Somali, are the largest in the world, the largest refugee camps in the world. And we're getting a constant now inflow from Somalia. I think one of the things that we're hearing from the colleagues there who've been doing a lot of work and excellent work on working with communities, working with men and boys, working with women, women's health services on this issue, is that while the efforts have been very good and very productive, there's more and more people coming in. There's a turnover. There's new people that need to be reached. Okay, well, let's, I've got, I guess one of the things I wanted to say is just to underline the point that Mrs. Roswork made at the very beginning of this panel, which is something that really affects our work, since we're dealing with people who are forcibly displaced, whether across the international border to become refugees or within their own country. Increasingly, we're involved in conflict-induced, internally displaced persons, is this theme about the values and traditions. And in some ways, those who've been displaced, who have had to leave their homes and leave, they cling almost more than I think people in their home countries might to these traditions that give them a sense of rootedness. And that's something we're very aware of and trying to address as best we can. And just to reiterate also what one of the other panelists has said, is that we're doing this in the context of other programs. We don't address FGM as a standalone initiative. It's in the course of our work on women's and children's human rights, women's health services, children's health services, and increasingly in a lot of the other community work we do, even including support for livelihoods and other things, ways to support agents of change in the refugee communities. Because, as has also been described before, people who do stand up, people who do go against some of these traditional norms, face stigmatization and face isolation. So we're looking at ways to support them. Do I have time to... Oops, okay, well, there it is, and I hope we will have time for more questions. Thank you so much.
Thank